Thank you so much, Dr. Ansel. This is I appreciate the opportunity to be here. We're going to talk about kind of a pre and post, Pounce thrombectomy situation, similar cases, how we used to target them before, and some of the challenges that arose, how we target them now, in the world of Pounce's introduction, and really the ability to deal with organized thrombus for the first time. So, next slide for me. So let's flash back in time. The year was 2019. This was a 58-year-old patient. She'd had bilateral common iliac stenting performed 3 years prior for claudication at that time. She had a new diagnosis, actually, of ovarian cancer, had chemotherapy, had surgery for it. And initially, after her intervention, her symptoms had gone away. But she had, over the last 6 months, so again, we're years out from the procedure, really bad, severe claudication. No rest pain, no ulcerations, but really, really bad symptoms. We can go to the next slide. We've all dealt with these types of patients coming into clinic. We know this might not necessarily be acute thrombus. We know this might be the more organized stuff, and it's somewhat anxiety provoking. It was, especially before we had the right tools to do it. So we did what we always do. This is a non-emergent, non-acute limb case. We did an ABI. Her right side was normal. Her left side was significantly reduced even at rest. On her arterial duplex, she had monophasic parvus tardis spectral Doppler. Next slide. And she got a CTA. And on the CTA, we see that there's a thrombotic occlusion, so a total occlusion of left common iliac artery stent. We talked about options and we talked about risks. Historically, especially before some of these better tools like we're talking about tonight, we talked about the fact that attempts to try to fix this could convert claudication into acute limb ischemia. We talked about the dangers of distal limb embolization. And historically, we always made sure as a non-surgeon, as an interventional cardiologist, that the option was there for doing open cut downs and doing balloon thrombectomies on these cases to try to prevent those catastrophic outcomes. I actually talked it with one of my vascular surgery buddies and said, well, if we're not going to do vascular surgery, it's kind of a high risk surgical patient, at least we have surgical backup around in case things did go south. Next slide. And so we started the case. So that, we got right common femoral arterial axis. We take our first omni-flush aortogram. You could see kind of those bilateral common iliac artery stents, and we see that left common iliac artery stent is 100% occluded, just like on the CAT scan. Go to the next slide for me. Here's kind of a close-up. That wire crossed real easy, as you can see from that contralateral side. It's not because we're great. It's because that's kind of this pathway of organized and disorganized thrombus. We got a wire up and through it through a support catheter. We can see very clearly that complete occlusion with a little bit of a nub coming into the left common iliac artery stent. Next slide. And so again, the year was 2019. So we had the tools that we had at that point in our lab. We always do IVUS on any stent thrombosis to see what's going on. We saw that the stent was actually pretty well sized and pretty well opposed. It was just full of organized thrombotic material, kind of a combination of fibrotic scar and thrombus. Back in 2019, we angiojetted it. We did a pulse spray, we did rheolytic thrombectomy. We were trying to prepare that, get rid of as much of the fresh stuff and try to optimize the non-fresh stuff to deal with it. Go to the next slide. This was after our angiojet really looks great, right? Now, it didn't change anything. We weren't able to deal with that organized stuff with TPA or with pulse spray. This was a fairly small woman. We put a Cat 6, that's a small device, but probably she would be too tiny for the 12. We put a Cat 6 penumbra device up. We tried mechanical aspiration thrombectomy and really didn't get much out. We've all kind of been in this situation where we try the devices we have, there's organized stuff. We're still in the world of claudication, but we're worried that any next thing that we're going to do is going to cause that to embolize and turn a bad day into a nightmare. So next slide for me. I buzzed my vascular surgery buddy and I said, hey, we're kind of running out of tools for this organized stuff. I could try to balloon this. I could try to put a covered stent in here. There's a chance that it's going to embolize. We can do our best at first try an undersized balloon angioplasty, and then we'll think about covering it. So we tried just that. We put that small balloon up and we took the next picture on the next slide. And so we took the first part of this picture and my tech said, oh, great, look, it's open. And it was open, but not the distal part. Everything just moved. That big organized piece of thrombus just traveled from the common iliac artery to the external iliac artery. Go to the next slide for me. And so, well, now all of a sudden we had occlusion. It was just distal. We tried angiojetting again. We tried the tools that we had again, this time coming up from that left side, and we turned bad into worse. So on the next image, At this point, the patient has acute pain in the left leg, and you can see that we have thrombus that's now gone past our left common femoral arterial sheath. The patient had acute pain. This was a woman who walked in and just had claudication, and we all of a sudden we've turned claudication into acute limb ischemia. You can see that picture on the right side of the screen is just contrast hanging inside organized thrombus. And this is really the nightmare. This is taking the bad situation and making it 100 times worse. And we also now have thrombus beyond, actually below our left common femoral artery sheath. I buzzed my vascular surgery buddy. He turned his phone off at this point. He was tied up in a case. And so, we didn't have immediate options in terms of surgical therapy. So let's go to the next slide. So what do? Well, we crossed up and over. So despite the common iliac artery stents, we went up and over from the other side. We got a wire down into the SFA. We took a picture distal. We proved we were distaling the SFA. We put an embolic protection device down distal where all that thrombus was, just because we had a feeling we were going to keep pushing it down and trying to do everything that we can do. Let's go to the next. I'm reliving my PTSD from this moment. You can see here we have one sheath going above the clot. We have our wire coming down behind the clot, and we're kind of working contralateral, working beyond this sheath through a heavily accessed point. Just kind of a nightmare. You can pull that sheath out, but then all of a sudden this is someone you're giving TPA to who has a fresh arteriotomy in a hole while you're still working. So not a lot of great options. Next slide. And so we used the tools we were using. We kept angiojetting. We kept trying organized the mechanical thrombectomy that the aspiration thrombectomy tools that we had, pushing down beyond our contralateral sheath. You can see the angiojet device there going to try and infuse some TPA with the Duell, at least to try to get rid of the acute pain. Let's go to the next slide. And so when we did that, we got the pain better. You can see there's still a chunk of something organized sitting there, but we got some inline flow at least. So that was a pretty big win. We probably lost a chunk of flow into the main branch of the profunda, which was less than ideal, the lifeline of the leg, but at least our acute pain was better. So let's go to the next slide. At this point, again, we talked to vascular surgery, was available about what to do. It was like, well, we have some flow. Let's see if we could tack up what we have. We put a Viabond down from the ostial SFA down into the SFA. You could see that defect right at the origin. We were trying our best to avoid stent jailing the profunda with a covered stent. The profunda was partially gone. We had good runoff. We captured our spider EPD, and when we captured our spider EPD, go to the next slide. We lost flow again. So all of a sudden it just looked terrible again. We had acute pain again, and now we just have a Viabond stent sitting there. We just didn't have the tools to tackle this in our cath lab as of 2019. We knew this was an option. We knew this was something that we were worried about in advance. We talked to the patient about surgical options and therapies, but we gave it a shot in a high-risk surgical patient, and this is where we ended up. So she went to the operating room on the next slide. Credit to my vascular surgery colleagues. They did a left CFA exploration and then endarterectomy and embolectomy and a vein patch. They actually took that freshly paced Viabond stent out before it had time to scar into the vessel. They did an embolectomy in the left profunda. And so on the next slide, you'll see they had a pretty good result, but we ran that risk of turning thrombus, trying to use endovascular tools available in our lab as of 2019. We turned claudication into acute limb. I hated these cases. I hated these cases where you would say, I know there is a non-zero chance that I'm going to really create a bad situation here, try to do these things minimally invasively. We still tried because sometimes surgery just wasn't a great option. So let's go to the next slide. So now the world is different, and I don't want to be too dramatic about that, but it's 100% true. The way I think about these cases now, the way I train my fellows now for these cases is very different because we have the tools in Pounce to deal with the organized stuff, to deal with the rubber pencil erasers, like Gary mentioned, if they travel distally. So this is not the same case. This is January 2nd, 2024. So soon after one of our early kind of Pounce cases, similar patient presentation. This wasn't someone that came in with an acute limb. This was someone that came in that was like, I probably should have come in a while ago. My leg after my intervention started hurting again. We got a CAT scan. We saw exactly what we see here, which is kind of occlusion of the distal common femoral extending into the external iliac, robust collaterals coming off the internal iliac down distal to the leg. Next slide. And so, especially in a world where we have devices that can now go distal, and in part because I'm also jaded from prior experiences, including the ones I just showed you, we commit our focus to going up and over from the other side. So we did that. We went up and over. We used some tools and tricks. I'm a coronary guy, and so, we like internal mammary artery guides for getting up and over. We got up and over pretty easily. Again, this was kind of semi-organized plus organized thrombus. So there was an easy pathway to get a glide wire down across. We confirmed our position in the SFA distal to the occlusion. We put a 7 French destination sheath up and over into the left common iliac artery, stopping short of the actual thrombus. Next slide. And since we took distal pictures like you always do, of course, in these cases where you're worried about thrombus to make sure that we're not going to make things worse and just not have a picture of it from before. So we took our pictures and, there's this organized stuff proximally, but we also see that there's this PT that's open, the AT that's occluded, the perineal that's sluggish. And there's kind of this stuff at the trifurcation, which looks a little bit like it might be embolized material from the process that's brewing up top, kind of right at the trifurcation. So next slide. So that's what we were getting in and starting with. So our focus first was on the inflow, as always. We put an embolic protection device down distal on the level of the common femoral, and we started with the newer versions of aspiration thrombectomy, lightning bolt penumbra thrombectomy with that 7 French system. We got some stuff out, we got a little bit of a channel, but there was lots of this residual laminar thrombus. This is the exact situation that I used to dread before. This is a situation where I used to call the vascular surgeons before taking the next step because I had the fear that it was going to embolize and turn a bad day into a terrible day. We also had pretty limited flow kind of coming down into the profunda in this case. Go to the next slide. And so we did some more thrombectomy, and this looks pretty similar. We did a 5 millimeter balloon angioplasty. And the difference was in 2019, we did this and we said to ourselves, well, if it embolizes, we're going to the OR, and I hope something nightmarish doesn't happen. In this situation, we thought, well, if it embolizes, we'll just go get it. We have tools now to do mechanical organized thrombectomy of organized thrombus. Next slide. So after we angioplastied it, huge shock, it embolized. So all of a sudden, our external iliac looked good. But when we take pictures distally at the level of the knee, all of a sudden that popliteal that was there before and that PT that was there before is just gone. That little bit of the anterior tibial, which is kind of occluded distally, is back. It is present, but really there's terrible flow. And now we've got acute pain, just like we were having in that last case, but we've got better tools to deal with it. So let's go to the next slide. Same thing as before. You see contrast just hanging in that clot that used to be in the external iliac, and now it's sitting in the popliteal and it's occlusive now. We didn't have a way to deal with this before. We've all dealt with these cases before we had tools like Pounce. Before you just pack it, you just push it down distal and hope it gets into something that's not occlusive, and now you really have the ability to go get it. So let's go to the next slide. So I like coronary stuff. We put a run through coronary wire down at the anterior tibial. This is a bigger person. Over that, we introduced the Pounce delivery catheter. We introduced the basket wire. We captured it in the SFA above the level of the popliteal occlusion. So our pullback of the device was coming all the way through the trifurcation as well as through the popliteal segment. Let's go to the next slide. You can see the Pounce baskets being unsheathed. For those of you who have not seen that, kind of happening radiographically, pretty big person. So we're working in the proximal to mid tibials there with that device. Go to the next slide. You can see the individual steps there. So we're dragging the device back into the capture funnel sheath proximally deployed in the SFA above the level of that popliteal thrombus and occlusion. And you can see us kind of bringing that device back all the way through that popliteal occlusion. Let's go on to the next slide. Yep, perfect. And so this is our picture after one pass. We have a popliteal again. I can't tell you the number of ALI cases where you see the popliteal gone and you just don't have a tool in the armamentarium, before us 2023, 2024, and the ability to all of a sudden say the popliteal is gone with stuff that used to be in the external iliac, and now the popliteal is back. That's a transformative technology. That's not a minor step in the evolution of dealing with ALI. That's the fact that all of a sudden you can deal with something that you just couldn't deal with before. So the pop was back. Remember our pictures from before, the PT was the dominant vessel to the foot. We still don't have we still have some organized stuff that's occluding distal flow in the PT. Historically, if I happen to trip and fall and get this picture where all of a sudden I have the popliteal back, I would say, God bless, thank God, we're fixed, we're done. Now with the tools being what they are with Pounce thrombectomy, we kept going. So let's go to the next slide. So there's still some clot there. You can see that clot kind of moving into the PT area, which is why we don't have the flow that we had before. So let's go to the next slide. And so we put that run through down on the posterior tibial. We put that Pounce delivery catheter down distal. We actually ended up kind of getting across with we did it. We couldn't initially push the microcatheter down because there was some organized atherosclerotic vascular disease there. We did a little balloon angioplasty in that PTPAD, not embolized thrombus, to help us get the device down distal. So go to the next slide for us. And then just like we did on the other side, we put the Pounce system down, this time into the posterior tibial. Next slide for us. You can see us kind of deploying it. We took a picture after, and all of a sudden, we have run off into that posterior tibial. Now, if you ever have put an embolic protection device or you've done work in tibials, you'll see some spasm that happens in tibials. But man, the fact that we went from an occluded external iliac to a totally occluded popliteal with rest pain and zero tibial runoff to all of a sudden all that organized thrombus sitting on the back table with 2+ vessel runoff down to the foot. And we fixed the original problem. We fixed the problem that we caused, and we just confidently followed our plan and our procedure. That's a big deal. It's a pretty transformative change happening between a 2019 case and a 2024 case. Let's go to the next slide. So, final results on this, all of a sudden, we've reconstituted our flow. Our tibials before looked like that. Our tibials now look like that. So we got better AT flow. We took that thing out too that was sitting in the trifurcation of the tibial vessels, which we didn't even know, was that thrombus? Yeah, it was thrombus. It came out. It's sitting on the back table at the end of the case. And go to the next slide. The external iliac was fixed like we talked about. We've got good flow into the common femoral and the SFA as well. So let's go to the next slide. So in general, in conclusion, these considerations, these cases just weren't endovascularly treatable before Pounce. You had to live in fear of these cases. And now all of a sudden there's finally a tool available. I presented that first case at one of the large vascular conferences as a nightmare case I was hoping to protect other people from in the future. And at the end of that case, I started hearing about some of these novel devices for mechanical thrombectomy, and mainly what I now use all the time is first line with Pounce. This chronic organized stuff can't be broken up with thrombolytic. This chronic organized pencil eraser stuff can't be sucked out through a tube that's smaller than it. But the ability to drag it back into a system that can dehydrate it and remove it through a smaller tube, it's really just transformative. And I talk to folks that do a lot of acute limb ischemia about this. I talk to folks that never do acute limb ischemia, but get themselves in situations where they're putting devices through sheaths and putting devices through arteries that may have thrombus, that may embolize, that they have to deal with it. Folks just need to know and use this technology and feel comfortable with it because it really is a game changer. I think that's my last slide, Gary. Am I wrong? Oh, one more. So that's that concept of bailout, So if you're someone that does a lot of acute limb ischemia, this is going to open up a whole new world for the ability to deal with the organized stuff in non-surgical ways as part of a protocolized algorithm. And it's just an irreplaceable tool. We have Pounce on shelf with our ALI kits, but we also have Pounce on shelf with our pericardiocentesis and our oh no kits, which does not say oh no on the kit. It says something else because we want people to be able to deal with this and rescue these complex cases. So very good. So thank you guys for the time. It's really fun to think about how much has changed in this field over the last couple of years that's secondary to this technology.